Systems, Director of the Heart Failure Program. And we have one more presenter who I think will be coming. He's coming from another presentation, Mikhail Kosovorov, and we'll introduce him later. The RES technology is really a technology that has been validated for measurement of lung fluid volume. It is the technology itself is a vest that the patient puts on, and there'll be a demonstration I think later, and the booth is right behind this theater. And there are two electrodes in the vest, one on the front of the chest and one behind the chest. And an electromagnetic field is passed between the two electrodes, and the system analyzer, the base unit, analyzes the changes in the characteristics of those electromagnetic signals, and that it measures basically the dielectric properties of the tissue, which is really related to the percent of the mass that is being interrogated. What percentage of that is actually fluid versus air? This again is the system that you've seen. There's a home unit that the patients can use at home. There's a unit over here which can be used in the hospital setting, and the idea here is that for the home application, the base unit sends the information to a central database which analyzes the data and keeps track of information, and also sends alerts when the signals are out of bounds. There is an illustrious list here of centers that have been participating either as using the device as a commercial product, or also participating in the various clinical trials that are going on. So I've already introduced the panel, and what we want to do now is in turn here, have each of the panel members talk about their experience. To start, Dr. Abraham is going to give an overview to put this whole field in perspective. The issue of fluid management and telemonitoring, etc., has had a very long and checkered history, and hopefully now with this technology, we'll have broken part of the problems and actually provide a technology that is going to help keep patients out of the hospital and management at home. So, Bill? Thank you, Bill.
All right, thanks very much. There we go. Now you can hear me. Well, I just briefly wanted to highlight the need for a new tool in our armamentarium for managing heart failure patients, because clearly what we've been doing over the past few decades just isn't working. Our historical or traditional approach to monitoring patients' symptoms, their signs, changes in their daily weights, and their vital signs doesn't keep patients out of the hospital. And I show you a figure from a paper that was published in The Lancet a few years ago that reports results from a number of landmark randomized controlled trials. And you'll see in panels A, B, and C, trials that focused on signs, symptoms, daily weights, vital signs, all failed. Even more contemporary data, such as the BEAT-HF trial, led by Greg Fonero and others, has shown that these approaches to heart failure management just don't keep patients out of the hospital. The one exception shown on this side is the Champion trial in panel D, where measurement of intracardiac, or in this case pulmonary pressure, has a significant effect on reducing heart failure hospitalizations. Next slide. Oh, I have that, don't I? Okay. And I just thought this study, which was published late last year, was informative because not only do our traditional disease management programs not keep many patients out of the hospital, but they don't even improve patient quality of life. This was a VA cooperative trial study program, and look at the intervention, a collaborative, multidisciplinary intervention, a team consisting of a nurse, a cardiologist, a psychiatrist, a primary care physician, home telemonitoring, patient self-management support, and screening for comorbid depression. You would think throwing all of that at a patient patient would at least improve their quality of life, if not keep them out of the hospital. Well, the bottom line is that it didn't do either. Didn't improve their quality of life, didn't help keep patients out of the hospital. What's the problem here? We're measuring the wrong signals. Signs, symptoms, weight change, vital signs aren't the right signals. Actions based upon them don't keep patients out of the hospital. We need better signals, and those signals are lung fluid content and intracardiac or pulmonary artery pressure. And so what we need is an accurate, we need an absolute, and we need an actionable measurement of lung fluid content. And I can tell you now with some confidence that that is the REDS technology. So this data, which is published, looks at the accuracy of REDS compared to the gold standard assessment of fluid content in a tissue, and that is computed tomography. And you can see both in phantoms, in preclinical animal models, and in human subjects, the very high correlation between the gold standard CT measurement of lung fluid content and REDS assessment. Now, what about in the clinic? What data do we have to date supporting the use of REDS? It comes from an interventional study that was performed in Israel, and we're looking at a pre, then during REDS, then post-REDS data here. And you can see that from the time preceding the use of REDS, there was an 87% reduction in the rate of heart failure hospitalization. When REDS was withdrawn from these patients, the rate goes right back up. There was a 79% increase in the risk of heart failure hospitalization, and this suggests that active management of heart failure based on REDS has a significant impact on reducing heart failure hospitalizations. Well, let me show you an example here, and again, I think it's important to stress that in contrast to other non-invasive technologies that reportedly tell us when the lung is wet or dry, such as impedance-based technologies, REDS provides an absolute rather than a relative measure of lung fluid content. We know that a normal lung, your lung or my lung, has a fluid content that ranges from 20% to 35%, and ideally we aim using REDS to get patients into that 20 to 35% range, and ideally between 25 or 30%. We believe that results in the best improvement and lowest risk of future events, future heart failure hospitalizations. So here's just one example of how REDS can be used. You can see at the time of discharge, the patient does have a normally dry lung, but immediately following discharge, the trend is upward in REDS here. And this is a patient who inevitably would be readmitted if nothing is done. The trend's in the wrong direction. And you can see here that the investigator increases the dose of furosemide, and in response to that, the lung dries out again and goes back into the normal range. But the trend starts to go up again, and after the physician reduces the furosemide dose again, and so the trend goes up again, and the higher dose of furosemide is restored in this patient, and things come back down into the target or normal range. You can see here later on, the patient reduced their furosemide dose on their own. Things stay stable for a little while, but then began to trend upward again, and the furosemide dose was restored. And here the patient went above the level again and got some IV as well as an increase in oral, and came back down. But this is just sort of a real-world case of how you can use this to keep patients' lungs normally dry and to reduce their risk of heart failure rehospitalization. And this patient wasn't rehospitalized for worsening heart failure. In this particular case, here's a patient, and for time's sake, I don't think I'll go into great detail here, but a patient who was actually able to be tapered off of their diuretics and maintained within the ideal target range here. The diuretic was reduced from 120 to 80 to 40 milligrams a day with normalization of lung fluid content and a long-term improvement in patient outcome.
I think now we're going to move on to Dr. Ben Simone after that really nice overview of the concept and two examples of the use in the real world. And Dr. Ben Simone is going to talk about the various sites of care where this technology has potential to improve patient outcomes. Dan?
Thanks, Dan. We're a 6-hospital system in central North Carolina. We have a very busy advanced heart failure program. But part of our challenge is how do we extend our heart failure program out to the community? How do we get to other hospitals? How do we help other people who don't have access to the heart failure program? Currently, our reach is about 20 to 25% of the heart failure population we're able to attend to. So we're relying on other providers to provide care to 75 or 80% of the heart failure population, which I'm sure happens to many of your programs as well. So over the past 6 months, we've looked at trying to apply technology to many points of care to sort of help see where our services are most needed, and also to empower other providers to provide adequate heart failure care. And as Bill was saying very eloquently, what we need is a tool that we can rely on the information that comes back. So if you have someone out in the field and they're measuring fluid and they call you and say, I think this patient is volume overloaded, but I can't tell, that's a very hard call to field. And usually the reflex is just send them to the emergency room, I'll see him in the emergency room. Well, that's not the right answer for our system, and it's probably not the right answer for your system. So what I want is I want to call from the field and say, you know, their REDS reading is 40, and then I know we have an issue and we can deal with that issue. So if you look at the various points of care where we're trying to attack the problem, one point of care is at hospital discharge. So patients are getting ready to go home from the hospital service or the general medicine service or even the cardiology service, and they feel they're ready for discharge. We will put a REDS system on them prior to discharge, make sure they're adequately decongested, and then they can go home. And we're finding that about 30% of people who are felt ready for discharge just aren't ready to go, and really is one of the key factors leading to readmission. We're also now equipping some of our home health nurses. So after discharge, when the patients go home, the patient calls in a week or two and says, I'm short of breath. And the home health nurse will go out to them and look at them. Their neck veins don't look so bad, or they have a really big neck. They get a chest x-ray, it really doesn't show so much, and we don't know which way to go. So they take the REDS system out, they put the system on, and then they get a reading. And then we have a protocol, Lasix metolazone IV Lasix protocol, designed by our team, the clinical pharmacy team, that guides them through the triage process. Another thing we think where it's going to be also very, very effective is in nursing homes. So nursing homes now really have a big challenge in these bundled payments and macro situation is how can we keep patients getting adequate care in the nursing home without the reflex to send them right back to the emergency room. So what we're doing now is we're equipping these nursing homes with the vest, with the REDS system, in order that we can get detailed information back to us and co-manage those patients more effectively. And without taking too much time, our next project will be able to look at triaging patients in the emergency room. If you show up to our emergency room with heart failure symptoms, there's an 80% chance you're going to get admitted to the hospital. We want to triage those patients at point of care. If their reading is the low to moderate range, we want to treat them in the ER, see them the next day in the heart failure clinic, and keep them out of the hospital. So those are the different opportunities we see for the system. We're very excited about it. I'll run through 2 case scenarios with you, and then I'll pass the baton to Sean. This is a patient that was recently admitted to our hospital system. It's an 88-year-old gentleman. He has diastolic heart failure, moderate aortic stenosis, and pulmonary hypertension. He was admitted to the hospital service on June 25th with biventricular heart failure. His weight at the time was 188 pounds. The primary team actually took 26 pounds of fluid off of him with IV Lasix and metolazone. They also did a high-volume paracentesis. 4 days later, he was felt ready to go home. The time was ticking on his length of stay, so it was time for him to go home. So as part of our clinical trial, we put a REDS system on him, and we got a number of 39%. And if you'll remember from the previous speakers, this is above the target of 25 to 35 where we'd like to see the patient. The heart failure consultation was called. We came to see him. He was felt to be have a residual volume overload. We continued to diurese him over the next 2 or 3 days. We got 10 more pounds off of him, got down to a 33% number, and we titrated his diuretics. We've seen him back now in the heart failure clinic over the past 2 months. He has not had a readmission. His weight is actually down another 5 pounds, and at 88 years old, he feels better than he's ever had. And it kind of gives us the ability to say, how dry can we get these patients? This is my final slide here. This is an 86-year-old woman who was admitted to one of our outside hospitals, our sister hospital. She had multiple comorbidities, as you can see, also diastolic heart failure. Unfortunately, when she came to the hospital, she was found to have a newly reduced ejection fraction of 30 to 35%. She was discharged from the hospital on August 4th of this year on Lasix 40 milligrams daily. About 3 weeks after, or 4 weeks after her discharge, she called the home health nurse and said, I just don't feel well. The home health nurse went out and triaged her. Her oxygen saturations were low. She was felt to be volume overloaded. And based on the protocol, we doubled her Lasix to 40 BID. The nurse continued to go out there every day, and you can see despite doubling of Lasix, her reds reading continued to go up with no change in weight. And then we added, per protocol, we added metolazone, and then over the next 2 days, you see she decreased consistently down to 37. This is still a work in progress, but what you can see is that she clearly is not an optimal Lasix responder. She requires metolazone and may even require a switch to torsemide. So one of the other uses of this is to help us establish a new baseline diuretic regimen for this patient, so we know what's the most appropriate diuretic regimen for this patient. So just a couple of point-of-care uses for the device, which we think holds a lot of potential.
Thanks, Dan. So now we'll ask Sean to give his perspective on this technology and also show its use in some rather complicated patients.
Great, thanks, Dan. Why don't we take just a couple minutes and talk about how the RED system can help in managing some complex patients. This is an example of a patient who was treated in Israel, and you can certainly appreciate that this person, when they were discharged from hospital, was still red with very high lung volume content, measuring around 45 to 50%. This individual, this gentleman, had chronic kidney disease, but also had the advantage of having a physician coming to his home who administered IV furosemide to try to keep him out of the hospital. And despite attempts to get the lung volume content down into the normal range, it was very, very difficult, very challenging. We were able to reduce lung volume content to around 35% or so. And when IV furosemide was not administered, you'll appreciate that there was a regression and an increase in lung content volume, followed by a dose of IV furosemide and a decrease in content, followed by another increase. And so I think these are the types of challenging patients that we see who have chronic kidney disease, who are programmed to retain salt and retain fluid, but we can detect that by the vest, and we have actionable information that would trigger the use, in this case of IV furosemide, to try to keep this gentleman out of the hospital. That was ultimately successful, and you will appreciate that this individual was not re-hospitalized. However, the persistence of congestion, in this case measured by an elevated lung content water, clearly identifies him as someone who's at future risk for decompensation. But here's another end of the spectrum, and this is a young woman with peripartum cardiomyopathy who was hospitalized with decompensated heart failure. And at the time of her discharge, she was discharged with normal lung fluid content, was discharged home on diuretics, and was discharged home on a reasonable dose of carvedilol, an initial dose of 3.125 milligrams twice a day. And at her first follow-up visit, she was doing very well, normal lung fluid content, and was able to have her carvedilol increase. She was then seen a second time, appeared to be doing well, but several days after that follow-up visit was hypotensive and complained of feeling dizzy. Now, this is a clinical challenge that we all face. Are they dizzy because we recently increased the carvedilol, or are they dizzy because we increased the diuretics? Well, in this case, we see that she had a low lung fluid content, suggesting a low intravascular volume, and her diuretics were reduced, and the carvedilol was maintained at that dose of 6.25 milligrams twice a day. At her next follow-up visit, she's doing okay with, again, low-ish lung fluid content, and they were able to reduce her diuretics from daily dosing to as-needed dosing, which allowed them over time to further increase neurohormonal antagonists. And we know that by increasing neurohormonal antagonists, we can improve survival, we can reduce hospitalization, we can improve health-related quality of life. So this is an example where knowing that someone was over-diuresed through the use of the RED system facilitated the advancement of neurohormonal antagonism. So with that, I will turn it over to Michael.
So thanks, Sean. And those are certainly our challenging patients, and we face these kind of patients every day in their routine clinical practice. So, Mikhail, I introduced you just slightly before you got here, and Mikhail is the PI of the DEFINE heart failure trial. And Mikhail, can you explain to us your understanding of the REDS and how you chose to incorporate REDS into your clinical trials?
Right, so I kind of come from a bit of a different background and a little bit different emphasis. We've talked a lot about the clinical implications and how this REDS technology can be used in clinical practice. My angle is more on clinical research and clinical trials specifically, and I actually spent a lot of time doing clinical trials, trying to improve outcomes in patients that have diabetes and cardiovascular disease. And as many of you know, outcomes of patients with diabetes and heart failure are particularly poor, so we're trying to come up with new treatment strategies to improve those. As a part of that, there is actually a new class of drugs called SGLT2 inhibitors that were initially developed for treatment of diabetes, but now have shown a lot of promise as potential new therapy for heart failure, actually both in patients with and without diabetes. And one of the first trials that we're actually doing specifically dedicated to addressing that question is DEFINE HF trial, where actually we're evaluating dapagliflozin, one of the SGLT2 inhibitors, versus placebo to see if it improves intermediate outcomes in patients with heart failure and possibly heart failure hospitalizations. So a large part of this trial is really trying to understand the mechanism. It's really doing the mechanistic work to understand how, if the drug does have a positive impact, how does it do that? And we had a number of biomarkers, obviously, NT-proBNP, Kansas City cardiomyopathy questionnaire, 6-minute walk test, a number of other things that we would normally do in a patient with heart failure to understand if the drug works. But we also wanted to have an additional way of trying to actually show whether there is evidence of decongestion that occurs with the drugs. That's one of the things that, of course, cardiologists in general, heart failure cardiologists specifically, would want to know to understand how this class of agents may potentially work. And what we looked for was trying to figure out if we can find technology that could give us a non-invasive way of evaluating lung fluid and looking at whether the drug versus placebo has effect on decongestion, and also do it non-invasively and be validated in terms of its accuracy. And I think that naturally led us to REDS technology, and we're very happy that we were able to incorporate it into the study. And we'll see, we actually have an endpoint. One of the endpoints in the study as a part of this trial is going to be actually looking at REDS and effect of drug versus placebo and REDS measurements. I think it's going to be very valuable. Now, this is just one example, but I think as you kind of think about where this could go in the future from a clinical trial standpoint in evaluating novel compounds and novel therapies, it certainly is nothing specific about SGLT2 inhibitors as far as evaluating REDS technology as an endpoint, and whether any kind of novel therapy for heart failure could be evaluated through REDS to see if it has an effect on decongestion, and trying to give the cardiologists and other specialists an idea of what the mechanism may be. It's, of course, very valuable clinically, and I think opens up kind of new vistas in terms of what could be done, both in mechanistic studies, but also actually, we talk a lot about NT-proBNP and KCCQ 6-minute walk test being intermediate outcomes in clinical trials, and certainly if we see that this is, in clinical trials, appears to be correlating well with other endpoints and showing us some very interesting mechanisms of how, both this class of drugs, maybe other novel therapeutics work, this could become potentially one of the new intermediate endpoints to evaluate in clinical trials.
Thanks very much for that really great overview of your study and the use of REDS as a clinical endpoint. So I think overall we've provided a background for the rationale for the need for a new measure to assess volume status in these patients. We've provided in this very short time, some of the validation data that shows that REDS correlates with CT assessment of volume status, and also that in the pilot studies that have been done, that there is a reduction in hospitalizations in patients who are managed as outpatients. We've shown that there is various points of care where this has the potential to really impact on the outcomes in patients. We've looked at several cases, specific cases, especially particularly challenging patients with very complex diuretic needs over time. And then we've also now seen the incorporation of REDS as an endpoint into a clinical trial. So with that as an overview, we still have a couple minutes for questions for the panel, if anyone has any questions. Yes?
Dan, could you or anyone talk about how the signal performs in patients who have intrinsic lung disease, pneumonia, breathable disease, anything like that?
Want to take that?
Yeah, so at least at the present time, and of course we're still gaining experience and data on this, but so far, chronic pulmonary disease, it seems to perform the same. One would expect that if through the zone that the radar passes through, there's a pneumonia, that it may affect the signal. And again, this is all pattern recognition stuff. We're still, accumulating cases to understand that better.
Yeah, I think that's right. That a patient with a pneumonia specifically, I think there would be an issue. But I think with COPD, which obviously most patients have, I don't think that there's any issue with that. Any other questions? Yes, we have one in the back here.
Simone presented, it sounded like it was more of an assessment, like an ER triage, or one time the home health nurse takes it with them and applies it. But I got the impression it was more of the patient could go home and discharge and wear it for so many days or indefinitely. So what's the major slant for it?
I think I'll let Dr. Ben Simone answer, but the idea is that the technology is very flexible and can be used in different modes depending on your setting. So that was really, I think, what Dr. Ben Simone did.
So I think you hit the nail on the head. I mean, that's perfect. The device and the system has been proven to work on a day-to-day basis in the home setting to keep the fluid level down. What we're working on proving is that it's an amazing point-of-care device. No other device will let you be portable and go into the home at point of care, either with a paramedicine, a nurse, or at discharge to get the same one-time reading. So we really see a unique opportunity for this device in a space where no other devices can give us that information.
Cost? Just wondering the cost.
Cost. I think for those better, I think it's better to talk to some of the representatives from the company, which the booth is right over here afterwards. Any other questions? Yes.
Portion of it.
So the question is there a consumable? So this is the vest, and it's can be used again and again. So I think at this time there's no consumable.
So one of the concerns our infectious disease people had was spreading of germs. And the nice thing about the vest is it reads through clothes. So we put a blue isolation gown, just those isolation gowns you have on the outside, put that on, read over that, and it works fine. So it can be used over and over.
Any other questions? Well, we just finished exactly on time, and we want to thank you all for coming, and hope this was informative for you. Thank you.